Good morning, Prof. We are delighted to have you today towards this web seminar. We are very happy that you agreed to spare your Sunday hours, early hours towards Idea Clinic's special guest lecture. We have your teacher, Professor B.K. Sahai sir, who is chairing your session. I would pass on to him to say a few words. If he remembers, sir, do you remember? Okay.
I remember Wasim quite well. He used to be one of our good students. And then I met him in one of the IDF conferences when he was working on the Southeast Asians in UK and in cardiovascular disease manifestation. It's nice to be given an opportunity to chair a session to be addressed by you, Hanif.
To say about Prof. Wasim Hanif, Prof. Wasim Hanif is a professor of diabetes and endocrinology, consultant physician and head of services in diabetes at University Hospital Birmingham. He is a board member of Center for Diabetes, Endocrine and Metabolism, University of Birmingham, and Clinical Advisor Group, lead for research in diabetes and endocrinology at Institute of Translation Medicine, Birmingham. He works with several national bodies and professional groups in the UK. He is involved as a chief and principal investigator in several international multi-center trials and was instrumental in setting up UK ADS, United Kingdom Asian Diabetes Study. He is the chair of the Diabetes Working Group of World Recognized South Asian Health Foundation. His involvement in NICE has been extensive, sitting on advisory NICE Health Technology Appraisal Committee between 2009 and 2015, and acting as an advisor on definitions of obesity in British South Asians, prevention of diabetes in high-risk groups, physical activity, and type 2 diabetes. In a nutshell, Prof, unlike most of us have trained in the UK, but I think very few. Being a Hyderabadi, he has excelled beyond expectations. He is one of the most popular, endocrinologists in the UK, and we are proud that he hails from the city of Hyderabad. And today we are delighted to hear him out on the topic on update on cardiovascular trials in diabetes. Up to you, Prof.
Thank you, Shyam, for the kind introduction. I hope you can hear me. First of all, I would like to really thank my teacher, my group, Professor B.K. Sahai. I'm really honored that he is chairing my session. I was not only his student, I was also the student of Madam Professor Chandralekha Sahai. And I still remember working in a unit. She was at Gandhi Hospital, where I did my training. So it's an absolute honor to be able to speak where an eminent authority like Professor Sai is chairing my session. So I'm really touched. I've known Shyam for a very long time. We worked in UK together. So I think thank you very much, Shyam, for the kind introduction. Today, I was asked to give this talk on an update on cardiovascular trials in diabetes. Now, I think when you're giving a webcast, it is a bit of a challenge as well because you really don't know what has been spoken before you. But I think what I have done is I'm going to touch upon the clinical trials and try and give a kind of a perspective, or rather my perspective on these as to what they tell us and what they have to, what they can do and what we need to hear from them. So with that, let me start my presentation. I think in the next 25-30 minutes, I'll probably try and briefly touch on these areas, and then we take it from there. Now, I think the way to approach diabetes and cardiovascular disease, especially with the mind of what we call South Asian or Indian context in mind, because that's where I've done a lot of my work, is to really find out at what happens when you reach the age of 60. Now, at the age of 60, if you do not have diabetes, I think you've done well in life, which means that the amount of life years you actually lose is not much. So this has been one of the issue or debates currently in the UK, that if there is a 75 or 80-year-old person with diabetes, is it worth treating them or not? Similarly, if you have diabetes at the age of 60, and you lose about 6 years in life, which is amazing. Recently, last year, for the South Asian Health Foundation conference in the UK, my good friend Nikhil Tandon was there from All India Institute of Medical Sciences, and he said that currently in Delhi, about 40% of the people at the age of 60 have got diabetes, which I think is quite astounding, which means you average, you lose about 6 years of your life. Now, along with diabetes, if you have other risk factors, like if you had a bit of an MI, which a lot of people have, or a stroke, then you're talking about losing 12 years of your life, which effectively means that post-retirement, all the gains that you have earned are going to be lost. Now, currently there have been a lot of advances in the management of cardiovascular disease. The way I look at it is and I'm looking purely from the macrovascular complications of diabetes to see what is actually known in terms of improving life or making people live longer. So one thing we know for sure is antihypertensive therapy works. And, trial after trial have shown that better control of blood pressure actually makes people live longer. We also know that controlling cholesterol with statins actually works. It actually works, and it helps to improve life. So these two factors are well known. Now, when we come to antiplatelet therapy, you're talking about aspirin or clopidogrel, but post-MI in secondary prevention, also we know it works. Now comes to what I call the million-dollar question. What about glycemic control? Does it work? Does it really improve life? Now, the way I will look at this question is slightly, I'm going to be talking about the details of the clinical trials in terms of what is happening. But what is important to understand is that controlling sugars in some clinical trials works, and in others it doesn't. Now, one of the issues, the way I will look at this, is to understand what is important so far is what do we do to control the sugars? And I think the medication is becoming more and more important. For example, we all know metformin works, but very few people actually know that all the evidence that metformin actually improves cardiovascular outcomes in people with diabetes actually comes from a small cohort of nearly 330 patients in the UK PDA study, where the comparator drug was sulfonylureas or insulin. So what it is actually showing is perhaps not metformin doing its job, or it could be doing its job, but the harm which the other agents can cause. Similarly, we know from the ACCORD trial, in which it was shown that tight control of sugars actually worsens your cardiovascular outcome. In this study, the drugs that were used made people put on, in some cases, up to 3 stones or 20 kilograms in weight. And they also caused them to have severe hypoglycemia. And all these factors could actually make your cardiovascular outcome bad. So I think that is something very important. Weight loss and lifestyle intervention, although we insist on it and we make our patients do it, the cardiovascular benefit of that is not very clear. If you look at trials like Look Ahead, it doesn't show. Studies like Direct shows that it reverses diabetes. So it is still the jury is out on weight style in terms of cardiovascular factors. I always find this trial to be very fascinating because this actually gives us an idea as to actually what we can do to our patients currently. And this is a Steno study. This is a very small trial of nearly 160 patients in each arm, in whom the whole emphasis was to control their sugars, control their cholesterol, control their blood pressure. And so, very simple trial, 3 factors that you're trying to control. And what this trial actually showed was that if you actually do this, you actually reduce the death in these patients were nearly 46%. And this actually translates in a 21-year follow-up of adding 8 years in life. So in the similar patients, if you remember, at the age of 60, where you lose 6 years of life, if you do these three factors, you actually add in 8 years of life. And this is something what we have been doing. Now let us try and understand what is happening for diabetes over a period of time. Over a period of time, a lot of things has happened to diabetes, and in the general, things are actually improving. So this is actually a secular data from the New England Journal of Medicine from the United States registry. And what it actually shows is that over a period of 20 years, acute myocardial infarction, the outcomes are improving, stroke outcomes are improving, amputations, the outcomes are improving. So most of the major macrovascular complications of diabetes, we're doing very well, which I think is good. But what is important to understand is this, and this is a very simple data. What it actually shows is death after myocardial infarction. This is 1 year mortality. So after you have had a myocardial infarctions, what proportion of people die within a year? And this, you could see that in 1994, if you did not have diabetes, when our outcomes were not very good, nearly 15% of the people died after a myocardial infarction. Currently, that number is down to 15%, which is absolutely brilliant. Now, if you actually look with people with diabetes, still there have been huge gains. In 1994, a third of the people, 30% of the people would die after a myocardial infarction within a year. That number has improved, and it has come down to 15%. But this 15%, as you would see, is still 2 decades behind than people without diabetes. So what we are actually saying is that all the gains that we have done in diabetes, we still lack 2 decades behind in people without diabetes. We have been quite lucky in diabetes that over a last period of 2 decades, we had a huge number of clinical trials. Some of them strategy-driven, some of them product-driven, and these trials have really improved understanding about diabetes and how we should be managing them. So this is just to give you an idea about all these clinical trials that have happened during this period of time, nearly involving 100,000 patients. So that's a lot of patients. So what have these trials have actually said? Now, when it comes to microvascular complications, it's very clear. Be it DCCT, UKPDS, Advanced, Accord, BADT. All of these trials have actually shown that if you control your diabetes, you reduce your microvascular complications. That is your retinopathy, nephropathy, enterosection, and neuropathy. But when it comes to your cardiovascular or macrovascular outcomes, the jury is not very clear. Some of the trials, like the UKPDS, have shown that long-term follow-up of up to 10 years actually shows some benefit, while the other trials have not really shown that. So, and if we actually club all these clinical trials together, we have got nearly 100,000 patients. And if we look at one standard measure, macrovascular or cardiovascular events or cardiovascular outcomes, and if you look at the forest plot, it favors glucose, although marginally it favors glucose. So what we know from this meta-analysis is that putting all the trials together, controlling diabetes does help, but you have to do it for a long period of time. So this is what is known currently in terms of our practice on managing type 2 diabetes. And that is that in the first 8 to 10 years at the time of diagnosis, if we control the diabetes very tightly, we actually produce what is called as a legacy effect, and that not only lasts during the period of the control, but even after the control has slipped off. And this results in about 24% reductions in microvascular complications, 15% reductions in MI, and 13% reductions in all-cause mortality. Now things actually started changing, and based on that, this is what we have got, what I call the standards of medical practice. So this changes whether it's the ADA, ESC guidelines or NICE guidelines, but generally the principle is that after lifestyle we give metformin, and once after metformin we pretty much open the door giving any drug, and we use this lovely word saying we individualize the treatment, which is you can either use a sulfonylurea or a prednisone or a TPP4 inhibitor or a SGLT2 inhibitor or a GLP-1 receptor agonist or a basal insulin, and then we mix and match. So till now, this was the understanding of our diabetes, and the main reason this was our standard approach was that we knew the evidence, but we did not really know as to the agents that we're using for the management of diabetes, whether they actually save lives or not. Things started changing, and things started changing, as we all know, in about 2006, where the famous Nissen meta-analysis came, which showed, wrongly so, on reflection at this time, that rosiglitazone actually increased mortality in people with diabetes. And following this, there was a huge hue and cry, and rosiglitazone was actually withdrawn from the US market and the European market and pretty much disappeared from everywhere. Following which, the FDA came with this criteria saying that all the new drugs that are launched in the US should have what is known as a cardiovascular outcome trial. And in this cardiovascular outcome trial, what they need to show is a very simple thing. They had to show that they were non-inferior against the current regime, which means that they did not increase cardiovascular mortality. So the verdict from FDA was very clear. The new drugs had to demonstrate that they were safer when compared to conventional agents. But at the same time, if the agents showed that they were actually better than the conventional agent, that was an added bonus. So once this trial came in, a lot of evidence has actually helped us, because almost all the agents that are actually trying to gain the US market have started doing cardiovascular outcome trials. Although this has improved evidence, it's come with a new problem, which I'll probably talk about later. So what we have got? So we have got trials around the DPP-4 inhibitor. So we had a trial on saxagliptin called SAVIOR-TIMI. The headline was, when it comes to 3-point MACE, which is the major adverse cardiovascular events, it did not show any benefit. Rather, it did not show any harm, would be what the investigators could interpret. Similarly, with examined alogliptin, similar results. With sitagliptin, TCOR study, again, very similar result. Even one of the GLP-1 agonist, lixisenatide, a very similar result. So all these drugs, what they demonstrated was they were safe to use in people with diabetes, but did not have any cardiovascular benefit. Things actually changed, and I was one of the few people, as many of you in the audience would be, when we were at in Stockholm, when this clinical trial was actually published. And this was one of the first clinical trials in diabetes after a very, very long time, if you ignore the small cohort of metformin in UK PDS, which actually showed cardiovascular benefit. And this was considered to be amazing. So the 3-point MACE, you can, if you just remember, this number has this ratio of 0.86 with a confidence interval of 0.74 to 0.99, which means it was significant. Most of it was driven by decrease in cardiovascular death, which was about 38% decrease. Non-fatal MI was also decreased by 13%, although there was a slight increase in the non-fatal stroke. So this was one of the first trials with an SGLT2 inhibitor, empagliflozin, showing cardiovascular benefit. Following this trial, last year, the CANVAS study, which was with another SGLT2 inhibitor, canagliflozin, was presented at the ADA and published in New England Journal of Medicine at the same time. Now, the CANVAS program was slightly different because it had two trials. So it had CANVAS and CANVAS-R, and these were two different cohorts of patients which the investigators had brought together, and this came with its own problem. But the 3-point MACE, which is what we have to look, the primary endpoint, again, very similar results to EMPA-REG, 14% reductions, 0.86. And now here, if you look at it, it was more evenly distributed both in terms of cardiovascular death, non-fatal strokes, and non-fatal MI. At the same time, having a more positive effect on the secondary outcomes. But the CANVAS study had a bit of problems, and the problem was when it came to amputations. So what this study showed was when it came to either minor amputations or major amputations, there was increase in about twofold. Now, the way I look at this data is two things. One is very obvious. In a clinical trials, canagliflozin has shown twofold increase in the rates of amputations, and this is the reason why the labeling in the United States and the European Union changed for canagliflozin. But I think if you actually look at the data, so when you're looking at the actual number of events that happened in CANVAS, is very similar to that happened in the EMPA-REG study. Let me explain this. So if you actually look into the treatment arm in which the drug canagliflozin was used, or in the trials in which empagliflozin were used, the number of event rates of people having amputations was actually the same. But the difference was, in the EMPA-REG study, the people in the placebo arm also had a very high rates of amputations. While in the CANVAS study, the number of amputations in the placebo arm was very, very low. And that could be the reason why this became statistically significant. The question is, why did this happen? One of the reasons was, as I mentioned to you earlier, CANVAS was not a single study. It was a combination of two studies, CANVAS and CANVAS-R, which had two different cohorts, and CANVAS-R had patients with renal disease, so the amputation rates could be low. So that is something which could be the reason, or there could be a biological explanation. And at the moment, Janssen is doing a number of clinical trials, and Credence is one of them, which is just reported, which I'm going to touch on later on to look at this issue. Now, once we move from the SGLT2 inhibitors, we had the GLP-1 analogs. Now, the GLP-1 analogs also had a very similar trial design, and this was the liraglutide study, which is the LEADER study. And this LEADER study also, for the first time, showed cardiovascular benefit in its primary endpoint, which was the 3-point MACE, cardiovascular death, non-fatal MI, non-fatal stroke, 13% reductions with a hazard ratio of 0.78 to 0.97. Semaglutide is another agent, Sustain 6. I'm not sure whether it's available in India. It's going to be launched in the UK later on in the year. It's a once weekly GLP-1 analog that's found to be extremely effective in terms of both HbA1c reductions as well as bringing down the weight. Again, the cardiovascular outcome trials with Sustain 6, again it showed about a 26% reductions in the primary outcome with an equal distributions of cardiovascular death, non-fatal MI, and non-fatal stroke. So if I actually put a summary of the three trials together, because CANVAS was pretty much similar, this is what we find. So when it comes to the macrovascular complications, EMPA-REG, LEADER, and Sustain 6, all of them showed superiority in terms of the primary endpoint. The way they reached the superiority was slightly different. In EMPA-REG trial, it was mainly driven through the reductions in the cardiovascular death, while there was a slight increase in the non-fatal stroke. In LEADER, it was much more evenly distributed across the three ends, similarly in Sustain 6. But when it came to the microvascular complications, EMPA-REG showed a decrease in nephropathy, while there was not much effect on retinopathy. LEADER also showed a decrease in nephropathy. Sustain 6 with semaglutide showed a decrease in nephropathy, but the incidence of retinopathy was actually increased. We don't know why this happened, whether this was caused by a sudden drop in HbA1c because semaglutide is a powerful agent, or was it because of something else? So currently Novo Nordisk is doing another clinical trial to look at the incidence of retinopathy with semaglutide to see whether there is a difference. So if we do a summary of what is similar between these clinical trials and what is different, this is what we found. What we see with the SGLT2 inhibitors trial is that the clinical benefit or cardiovascular benefit occurs very early in the trial. Within 6 weeks, 4 to 6 weeks, you start seeing the benefit. With the GLP-1 receptor agonist, you need to wait for at least a year before you see the benefit. What is also important to see is the heterogeneity in terms of magnitude and directions for individual components of primary outcome in EMPA-REG and SUSTAIN-6. So what it really means is that the beneficial effect in terms of reaching the primary endpoints which we're seeing in these clinical trials is coming from the different components of the MACE. It's not the same components coming from different components of the MACE. In terms of retinopathy, what we see is that with semaglutide is an outlier which showed increased significantly higher rates of retinopathy when compared to placebo. The other important point we need to understand is that the proportion of patients initiated insulin during these trials was much higher, especially in the placebo group. Whether this was having some effect, whether insulin was responsible for increased cardiovascular outcome, we don't know. Incidence of any hypoglycemia was similar between groups of EMPA-REG and SUSTAIN-6, but significantly lower for LIRA versus placebo. Again, whether hypoglycemia was playing a role as in the ACCORD trial is something that needs to be looked into. And the other important point was the greater HbA1c reduction was observed with GLP-1 receptor agonist, whether that was having a positive effect. Sorry, I'm just having a bit of a thing to... So what we know is, are the positive macrovascular outcome observed due to reasons beyond glucose lowering? We will try and understand this later, or whether it's just the glucose lowering, or is there some different effect, whether the SGLT2s are causing a diuretic or a hemodynamic effect, whether GLP-1 receptors have got an atherosclerotic effect. Now these are the questions that we perhaps will know or will come to know in later years. But there are some other important questions, especially with an Indian context. And the questions are these findings representative of all subgroups? Because most of in the clinical trials, majority of the patients were white Europeans. And are these findings pertinent? And the second important thing we need to understand is that the most of the patients in these cardiovascular outcome trials were high-risk cardiovascular patients. So whether these findings could be transferred to low-risk cardiovascular patients, or what we call the primary prevention, which will be most of our patients, about 70% of our patients. Now, these are some of the key unanswered questions. Now, the way to really look at answering this question is two. Now, one way is to do still larger clinical trials, still having a larger cohort of the patients, in which we see the patients and perhaps follow them for a longer period of time, for 10 years, 20 years, to find out these answers. But the most difficult question in trying to do that is the cost. Let me just give you the example of T-cost, just to give you a perspective of how much these trials cost. The sitagliptin or Januvia is made by Merck. The average, the market of sitagliptin globally is about $6 billion. The T-cost study cost Merck $500 million, $500 million, $500 million. And after spending $500 million, what they established was cardiovascular safety, which is good. But what is now happening is that all these clinical trials are actually adding a cost to the drugs. And somebody has to bear the cost. So where is the cost going? The cost is going to the patients. So one of the things which is becoming quite a bit of a challenge in all the countries, especially in the emerging economies, is that all these agents are being found to have cardiovascular benefit, but our patients are not able to use it because these drugs are expensive. And some of these expense of these drugs is actually coming from doing the clinical trials. So we can keep on doing the randomized controlled trials, but they're going to add on the cost. So one of the questions that is actually pertaining not only the academics, but even bodies like NICE, which were big kind of big supporters of randomized controlled trials, or even the FDA, is to start looking at the other ways where we can actually demonstrate cardiovascular superiority of some of these drugs, especially in populations which would require larger trials or larger amount of money. Now, the way this is actually being done is by looking at what is known as the real-world evidence. Now, I'm sure if some of you have been to the ADA this year, they had actually a full session on real-world evidence. So let us see what is real-world evidence. So the real-world evidence is actually trying to look at what are called now validated registries. So we have got very large registries across the globe, and I'm sure even in countries like India, large registries are being set up, which have got data of patients, which have got good clinical data, and that's why they're called the validated registries. And in these validated registries, if the clinical trials are done with good methodology, which is now being developed because we are getting better at analyzing big data, we should be able to answer that question. So at University of Birmingham, we have got a very large unit, which actually is looking at what is known as the real-world data. And this actually looks at some of the validated registries. We look at 10. We have got these guys who are not statisticians, but what we call the bioinformatic guys, who are able to develop these very complex programs that actually help us to understand and answer these questions. And as the way things start moving, we will be hearing more and more of the real-world data. Because previously, whenever we talked about real-world data, we talked about some Mickey Mouse trials being done with very small things, mostly driven by industry, which actually showed one drug was better in one population or the other. But these would be validated trials, and this is actually being shown because some of these publications are coming in high impact journal. So to answer these key questions, whether these drugs actually effective in people with low cardiovascular risk, or what we call primary prevention, and whether this could be seen in the others. So here I want to talk about two trials I was involved with. One is the CVD Real, which actually looked at validated registries in about 6 countries. And it looked at primary prevention. So the way they matched for the confounding factors which could affect CVD Real studies by doing a confounding scores. And what they found was that in all the SGLT2 inhibitors that we used, it did favor hospitalization due to heart failure with a hazard ratio reductions of nearly 50% with low heterogeneity score. And similarly, all-cause death was actually reduced in nearly all populations with reductions of about 50%. Now, this was one of our trials in which we looked at dapagliflozin in a population-based open cohort in thin database. And what we did was we were looking at only one thing. We were looking at death. So what we wanted to see was when the patients were exposed to dapagliflozin, what was their risk of dying when you compared with other oral glucose lowering agents. And the way we did was we actually matched for a number of controls, or what we call the confounding factors, and this is done through very complex statistical methods, and we had nearly 4,000 patients exposed. And this looked both at the total population as well as population of low risk, or what we call primary prevention. And these are some of the matchings that we do, from Townsend scores, which looks at social deprivations, to Charlson's comorbidity index, and this has been published in JCM. And what it showed was when it comes to all-cause death in the total population, dapagliflozin reduced it by nearly 50%. And similar numbers, 56% was seen in low-risk population of what we call primary prevention. Now, this is actually real-world data trying to give you, showing you the same direction of flow in terms of reductions of mortality as the others. So these are some of the clinical trials with the new agents. Now, we also had a number of older agents that have, over a period of time, showed that they could have a cardiovascular benefit. And in the last year or so, some of these trials have also been reported. So this was the TOSCA-IT study. This was a comparison of pioglitazone, sulfonamide given in addition to metformin and cardiovascular reductions. And this trial actually came into being following the PROACTIVE study, which there was a suggestion that pioglitazone could have offered a cardiovascular benefit in patients. So this study had nearly 3,000 patients. The mean age was 62 years, duration of diabetes was 8 years, HbA1c was 7.7, and prevalence of cardiovascular disease was 11%. And what this trial actually showed was, when it comes to the MACE, there was actually no benefit of pioglitazone when compared to metformin plus sulfonylureas. But what was reassuring in this trial was that the heart failure rates, which were considered to be high with pioglitazone, were actually not seen. Now, EXCEL was also a very interesting study, and this study actually showed how things can go wrong in a clinical trial. So EXCEL was with exenatide long-acting, or what is called Bydureon, with a placebo. Very similar inclusion criteria to the LEADER study, type 2 diabetes, anti-DM. 70% had prior MI. Now, this trial, in its coming to the primary cardiovascular outcome of 3-point MACE, did not show cardiovascular superiority, although it did show that it did not cause harm, or the non-inferiority target was missed. But if you look at the hazards ratio here, was 0.91. And if you remember, in the LEADER study, it was 0.87. So the hazards ratio is 0.83. So it just missed its target by the fact that the number of events, if it had about 6 or 8 more events in the less events in the exenatide group, it would have reached statistical significance. So if you actually look at the number of events in exenatide, numerically it is less, while in placebo it is more. So although this trial did not reach its statistical significance, the trend of it was towards showing cardiovascular benefit, and similar numbers you see with all-cause mortality, again showing some benefit of these agents. Acarbose is again one of the agents that's been used. So this was the ACE trial, nearly 6,000 patients with intention to treat. And again, the Acarbose trial, looking at the 5-point primary MACE, again did not show any difference between the treatment arm and the placebo arm, showing that Acarbose was perhaps did not offer any cardiovascular superiority. If you thought that was the end of it, currently these are the number of trials that are actually happening, over 130,000 patients, which will probably give us more answers. But at the same time, what we've got to understand is each of these clinical trials actually add up cost to the medications, which in most cases are actually borne by the patients. Some of the important studies to look out is the Carolina study, which is directly head-to-head comparison of linagliptin with glimepiride, and this will probably not only answer the question about about linagliptin, but more importantly, it will answer the question about the increased cardiovascular events or mortality with sulfonylureas that has come into question a number of times. So I think this is some of the trials to really look for. Similarly, DECLARE, which is a cardiovascular safety trial with dapagliflozin, is due to report at the American Heart Association meeting in November of this year. What is interesting about DECLARE is that nearly 60% of the patients in DECLARE did not have cardiovascular events. So this is more of a primary prevention trial, and the results of this would be very interesting. And then we have got Vertis with empagliflozin. Now, this is a very interesting study, which is we are part of the study, which has just reported its primary finding. And this was for the evaluation of canagliflozin on renal and cardiovascular outcome in participants with diabetic nephropathy. This trial has been closed early. And the initial findings that have been reported, the headline numbers that have come out, as they say, shows that they think that this trial is showing positive effect, both in terms of reducing cardiovascular outcome as well as the renal disease, while at the same time there not being any increased risk of amputation. So this would be something interesting to look for. Now, while we talk about all these cardiovascular trials, because of my area of interest in South Asian diabetes, one of the questions that we have to ask is, are these clinical trials representative of the South Asian population or what we call the Indian population that you are treating, and whether these could be translated? Now, this was a meta-analysis that we published a few years ago. And what we actually found was that if we looked at all the major clinical trials, which are about 12 studies, the South Asians were underrepresented in trials compared to global populations. And our conclusion was clinicians should exercise caution when generalizing the results of trials to their own practice. Now, when some of these major trials that were published, we actually worked with a number of these companies to get them access to data, as they had a reasonable number of South Asians to try and give us some answers. Now, this is some of the findings from the EMPA-REG study, and this actually is very interesting. Now, what it actually shows is it shows Asian, which includes people of Chinese descent as well in these clinical trials. But what is very interesting is that if you actually look at all the markers, 3-point MACE, 4-point MACE, cardiovascular death, all-cause mortality, the numbers are much higher in the Asian population when compared to the overall population. Now, these are some of the figures. So, if you actually look at the 3-point MACE in the Asian populations, it comes to 0.68, which is 32% reduction. If you remember, in the original trials, it was about 0.84. So the beneficial effect in the Asian population is shown to be much higher. Similarly, when it comes to cardiovascular death, in Asian patients, the reduction is much higher at about 56%. All-cause mortality, again, is higher at 36 patients. So it could be that some of these drugs are showing more positive effect in an Asian context. We don't know the reason for that. Than in the total population. So these are my final 2-3 slides, and the question that we have to answer, and I'm not going to go into detail with this, is how are these beneficial effects we are seeing with these new agents, with the SGLT2 inhibitors? I think in the short, there are a number of hypotheses that are floating around, right from what they call the Steno effect, that is in terms of reduction of glycemic control, blood pressure, weight loss, to a number of other factors. Personally, I feel that we may not really know how these agents work. It may take us a few years to find out. But one thing which is very certain is that the effect that we are seeing with these agents, statistically, in trial after trial, in the meta-analysis, is showing a consistency, which means that these agents do reduce cardiovascular mortality. And this is, I think, is the good news. And the good news would be that because of this, some of our guidelines or managements for people with type 2 diabetes may change. So with that, I come to my summary slide. So cardiovascular diabetes remains a burden in people with type 2 diabetes. Data in type 2 diabetes suggests lower glucose improves cardiovascular outcome, but we have to wait for a long time. Traditional glucose lowering therapy shows cardiovascular safety, but not a consistent impact on cardiovascular outcome. New glucose lowering therapies show differential outcomes, within and between the class, but little data on South Asians, and cardiovascular management in people with type 2 diabetes is complex and needs individualization of current options available. Thank you very much.
Thank you, Prof. Wasim Hanif. Excellent talk and very clear audiovisuals. So we enjoyed your talk. Due to paucity of time, we'll take only a few questions while the audience step in. My question to you, Prof, is we talk about prevalence of diabetes in India. However, is it more significant, the age of onset of diabetes amongst Indian youth? Unlike when we practice in the UK, the average age of the diabetic patient used to be 50 plus, I presume. While in India, it's the youth that are getting inflicted. In your you said about the age is a bigger factor for us than the prevalence per se. What are your thoughts on that, Prof?
No, thanks, Shyam. That's a very good question. You see, in Birmingham, which has got a very large Asian population, we actually are seeing diabetes not only in the fourth decade in the Asian population, we're also seeing it in the second or even the third decade. Now, we are actually running a clinic for young adults with type 2 diabetes, and most of them are actually South Asians. I feel the age of the onset, especially with type 2 diabetes, is the single most important risk factor when it comes to complications and the burden of diabetes, rather than all the others. So the age of onset is very important. So if you're going to get your diabetes in your 20s and 30s, your risk of developing complications is much, much higher.
Thank you. Vanaja? Vanaja Reddy is your student. She's in the audience.
Hi, Vanaja. Yeah.
Okay. You want to say something?
I have a question actually. So,
yes.
Prof. Hanif, so regarding the cardiovascular benefit of the empagliflozin, the Americans have actually said that you can use empagliflozin if you want to have a cardiovascular benefit for the patient, regardless. So, what is the take from the UK about this?
I think at the moment in the UK, I think we're lagging behind, because I think what NICE has done is NICE has actually said it's going to wait for the outcome of all the clinical trials before it gives the verdict on where the SGLT2 inhibitors should be used. But what I would probably wait is I would probably wait for DECLARE, because if DECLARE comes positive, then that will be the game changer, because that will establish that dapagliflozin and SGLT2 inhibitors have got a role even in primary prevention, because 60% of the population in DECLARE does not have a cardiovascular event. So this is a vast majority of our patients. Because if we actually look at the high-risk patients, or the patients in whom empagliflozin was found to be beneficial, the high-risk patient, that actually in the UK, when we looked at our database, that only benefits about 20 to 25% of the population. Vast majority of them don't have that kind of a high cardiovascular risk. But if the DECLARE becomes positive, then we actually move into territory where we will start using it in nearly all the patients.
One question from the audience.
Sir, what could be the reason to be Indian people are more prone for diabetes when compared to Western? Whether it is a genetic reason or dietary and social or stress reasons?
Thank you very much. I wish I knew the answer, because I think for the last 2 decades, all my research is trying to find out the reason. Now, one thing is certain, that the couple of things is there. The first thing, what we know is that when it comes to genetics, currently there is no genetic marker, because we've done one of our biggest study was the SAT2D study, in which we compared by genome-wide associations whether Indians have got any increased genetic risk. And what that showed was that there isn't any specific genetic factor that could explain. That doesn't mean it doesn't exist. But I feel personally it's very unlikely, because actually if you go back to genetics, most of the Indians would classify as biologically as a race as Caucasians, which means the genes between Caucasians and Indians are not much different. So where does it come from? It actually comes from the environment. And most of the time, it is the rapid change in the environment that is happening, both in terms of the average calorie consumption, which is increasing, and less of physical activity. And this is perhaps the factor that is actually contributing it. And it's not only happening in India. If you actually go to China, the prevalence rates of diabetes are increasing immensely over there. And it's happening in the Middle East. It's happening in Africa. It's happening in South America. Even in countries like UK, where previously people thought that the prevalence rates were low, the prevalence rates are going up. So I think most of it is actually being driven by lifestyle. There is a very interesting paper that came in about a few months ago, and this is from Finland, where for the first time it has been shown that the incidence rates of diabetes are going down in Finland. And this has been possible by people changing their lifestyle completely at a population-based level. So although genes may be a factor, I still feel it is the environment that's driving the epidemic.
Thank you for that. I think due to paucity of time, I think we will end this session. I once again thank Prof. Sparing his weekend hours towards this beautiful talk he has given us, and looking forward to his visit to Hyderabad next month. Thank you, Prof.
Thank you, Shyam. Thank you. Thank you.